All right, guys, welcome back to the next section of our class notes in the knee unit. We've gone through the bone anatomy section. Now we'll jump into the soft tissue. Soft tissue section will comprise of ligaments, muscles, and the meniscus. Then after that, I'll stop this video segment and do a totally different one for patellofemoral assessment. So look for both this video and the next video this week as part of your notes. As you'll see, I've split the screen here so you can see the PowerPoint and your notes. Follow along with your notes and fill in what you need to fill in. All right, so first off, when we talk about ligaments, ligaments are static stabilizers. Static means they hold it in place while we're not moving. So if we didn't have our ligaments to hold our knee in place, we would fall down, we would fall over, we would not stand upright. So here in this picture, you see the two in the middle, the ACL and the PCL. You see the two on the sides, MCL and LCL. LCL, L is lateral, so you look for the fibula here, and it is going to attach to the fibular head. MCL, it's going to be on the medial side, so you don't see the fibula. It comes around all the way to the underneath part of the tibial plateau, right? So when we talk about MCL injuries are injured by a valgus force. Valgus force, as you see in your notes right here, valgus force come from the outside. So when you get hit on the outside of your knee and it buckles in, it creates an L shape. And that's because the knee joint is opening up. The way to remember it's a valgus force is it has an L in the word. So there are two parts to the MCL. The MCL has a deep and a superficial part. Most MCL injuries are just to the superficial part or the one that's near the surface. All right. When you start getting into the deep part of the MCL, you start looking at, did we tear the meniscus? Did we tear the ACL with it? Sometimes that happens. So you can see here in this picture, this guy is coming in and hitting the football player up high, but it's on his plant leg. So he's already going in this direction. So he's adding more force from the hip, which is going to cause the knee to buckle to the inside. You see here on an MRI scan, normal MCL, you don't see any separation right here. Torn MCL, you see this blackened area. That blackened area means that there's swelling or inflammation. So it means that there's a tear. All right, moving on to the LCL. The LCL is the opposite of the MCL. Remember, collateral. Collateral means side by side, right? When you think of putting up collateral on your house or on your mortgage when you get older, most people will put up their vehicle or something against it. So if they don't pay the bill, then they're going to take the collateral to pay the bill. So they're going to take the car to pay the bill. Same thing. Collateral just means side by side. Okay, so one is going to help the other, and they work together to keep it from moving side to side. All right, so the LCL is not commonly injured in sports. I think in the 22 years of doing athletic training, I have seen 3 major LCL injuries. 2 of the 3 injuries came from cheerleaders, and unfortunately, those injuries came from them in a pyramid when the flyer was coming down and the back spot didn't cushion the fall correctly and hyperextended their knee. The third injury was in a basketball player. So like I said, they're not very common, but they do happen. The LCL is on the outside of the knee. It does not attach to the lateral meniscus. So when that outside of the knee, when your knee rotates side to side, it moves out of the way. And the reason for that is because of its attachment onto the fibular head. All right, so those are on the sides. That's what collateral means. If we move to the next two, the ACL and the PCL, they are called cruciate ligaments. If you look up the word cruciate, it has a root word of cruci. Cruci means cross. So the ACL and the PCL pattern themselves in a cross, or crucify on the cross. Okay, so they pattern themselves in a crossing form. And that's important because one of them pulls in this direction, the other pulls in this direction. So when they're alternating their pull, they're putting tension into the middle of the knee to create a stable environment. All right, so the ACL attaches on the tibia and the lateral femoral condyle. So it moves up posterior or up superior, posterior, which is to the back, and lateral. The PCL moves opposite. We'll learn that in a second. Injuries happen to the ACL when you take an anterior blow to the femur or a blow from the front and hitting the femur, or with deceleration and rotation. The most common way an ACL is injured is by decelerating and rotating, which is a non-contact injury. Some of the most severe ACL injuries I've seen as an athletic trainer have been in that fashion. So if we look here, they're both red, so it's kind of hard to see, but this guy here is coming behind this number 8 in the red. Here's number 8's leg right here. Well, he's planting and his other leg is up in the air, so he's twisting on the one knee, which is why his arm's going down to break his fall. Well, as this guy's coming in behind him, that twisting action is taking place, and it's basically just putting a lot of torque into the knee joint. From a diagram perspective, here's the patella. We've retracted or taken out the patella. So if we put the patella back in place, the patella is going to sit right here. The patella tendon is going to come down and attach right here to the tibial tubercle. All right. So this area is very much protected, which is one of the main functions of the patella, to protect the anterior knee. So this is looking through an arthroscope into someone's knee. This is a normal ACL. You see how nice and smooth it is. This looks like cauliflower. So what happens is it's a very stretchy material, not super stretchy because it's a ligament. Tendons are more stretchy, but the ligament has withstood its critical force, and so it popped and makes a loud sound, a lot of discomfort, a lot of pain, but then it just kind of shrivels up at the end because it doesn't have an end point. So it looks like just a ball of tissue. So what they'll do with surgery is they'll go in, they'll clean all this area out, and they'll take this little stump of the ACL out of the way, and then they'll reconstruct it. All right, moving to the PCL. PCL is opposite of ACL. It attaches on the tibia still, and it attaches on the medial femoral condyle. So it moves superior, anterior, medially, or up, forward, and in. If you look at the injury mechanism, it happens by an anterior blow to the tibia. So that would be like a hyperextension injury where the knee is straight and somebody gets hit in the lower leg. Torn PCLs are not very common. You can see here this dark black area. That's where the PCL should be, but in this artistically enhanced picture, you see there's a lot of blood in the area. So when you have a lot of blood in the area, it turns black on an MRI. Right? What you see here that looks kind of like a ribeye steak or something like that is the calf muscle. So here's the knee joint right here. You see the calf muscle actually comes up behind the knee joint and attaches to the femur, which is why sometimes in a calf strain, it hurts above the knee because of where it inserts or originates. It actually inserts into the Achilles tendon. All right, moving into the meniscus. The meniscus is a wedge disc that sits between the condyles and the plateaus. So it's like here, it's like the cream to the Oreo, all right? Your Oreo is the femoral condyle, the tibia, and then right in the middle that gives it that cushion is the cream filled. So the meniscus is like the cream filled to the Oreo, okay? So it lies between the condyles. The outer edge is thicker than the inner edge, meaning it looks like a pizza wedge. So it's thick and it moves in, okay? The outer part of the meniscus is vascular, meaning it has a lot of blood, so it's easy to heal. The inner part is not easy to heal, which is called avascular, which typically means if someone has a meniscus injury and it's in the outer part, they will typically do what's called a meniscectomy, which means they take the piece out. Why do we have the meniscus in the knee? We have it to enhance knee stability, enhance with motion, and act as a shock absorber. All right, a meniscectomy is the removal of the meniscus. The meniscus on the inside of the knee is C-shaped, and the lateral meniscus is O-shaped. Types of meniscus tears that we see in sports: bucket handle tears, peripheral tears, and avascular tears. Bucket handle tears are the most common. They occur in the middle of the meniscus, and avascular tears are not very nice because they take forever to heal and they have to be cleaned up really well. And typically you end up doing a meniscectomy with it. So you end up losing part of the meniscus because there's no blood supply. So if we look here, a bucket handle tear happens in the middle of the meniscus. A flap tear is where a little piece, kind of like a hangnail, just hangs off of it and it gets caught in the joint window. And then another common one is a posterior horn tear, which means it's happening on the back side. And it's, again, another little flap of tissue that just gets up in the way. Typically, all of these can be repaired. If they're in the avascular zone, they will be taken out. So again, you can see here, it looks like a very paper-thin piece of material in the body. So that's the meniscus, that's normal. And then a meniscus tear is very frayed. So this is because it's caught in the joint, a lot of rubbing, a lot of inflammation, and then it just tears because it becomes weaker. All right, moving into your muscles. Your muscles will be on a new video because I'm running out of time on this one. So give me a moment and I'll start you a new video for the muscles.